prevalent non-dermatological malignancy in the male population. Angiogenesis, as we've been talking about today, plays an important role in tumorigenesis. And certainly when we look, the vascular endothelial growth factor expression is increased in prostate cancer tissue compared to benign prostatic hyperplasia and even in benign tissue itself. Going a step beyond that, in the metastatic castrate-resistant setting, plasma VEGF levels have been shown to be increased compared to those with localized disease itself, thus bringing about support to target anti-VEGF, to utilize anti-VEGF therapies in this setting. In terms of the agent that we utilize, is cediranib, a unique orally administered drug with activity against all three VEGF receptor tyrosine kinases and the platelet-derived growth factor receptor. This is in contrast to the well-known bevacizumab, for instance, that only is targeting one of the VEGF-A receptor tyrosine kinase. In terms of the biological rationale to combine docetaxel with the angiogenesis inhibitor seemed to be a reasonable biological approach. We did show in our phase 1 trial with Dr. LaRusso, our head on that trial, that there was safety and tolerability with this combination, certainly not just amongst prostate cancer patients. It was in a wide variety of tumor sites. In terms of other studies, one other study also showed cediranib alone in the post-docetaxel setting showed progression-free survival data of 3.7 months and overall survival data of 10.1 months. Thus, this study attempts to combine, therefore, in the upfront setting, the docetaxel with the cediranib. Looking at the design itself is a phase 2 multi-center randomized design trial, with arm A having the cediranib dosed initially at 30 milligrams daily, along with both arms getting the docetaxel and the prednisone. The primary objective itself was 6-month progression-free survival. The secondary endpoints included toxicity, PSA response, clinical response, and correlative markers such as the serum VEGF levels before, during, and after therapy. Treatment continued until disease progression, intercurrent illness, unacceptable adverse events, or withdrawal. Disease progression utilizing both our standard methods of PSA and also utilizing bone scan monitoring every 2 cycles. In terms of our patient demographics, 58 patients enrolled, ultimately 57 were treated. On the arm, in terms of the active cediranib arm, was arm A, and the arm B was the standard docetaxel plus prednisone. The median age was 66 to 68 between the arms. We did have a strong, diverse population. 33% were African American. Performance status was essentially 0 to 1 on the patients. Of note, also, 40% of the patients had bone and visceral disease. Taking a look at one of the results immediately on this particular table is the PSA percentage change was higher in the arm A, 84.1% decrease compared to arm B at 61% decrease. Looking at the treatment efficacy results in itself, the main primary endpoint being 6-month progression-free survival rate was 61% in the cediranib arm compared to arm B, which it was 57%. This was not statistically significant with a p-value 0.7 on that. And we can also see the overall survival is not showing any difference between the 2 arms. The progression-free survival, as I mentioned before, the AZD2171 being the cediranib, there was no advantage in terms of progression-free survival. In looking at the outcomes itself, 9 cycles were given in arm A compared to 7 cycles in arm B. The important point of the dose reduction, it did, midway through the trial, we did decrease the initial dose from 30 to 20 milligrams due to significant neutropenias, and 62% ultimately required dose reductions, additional dose reductions. In terms of the docetaxel, 45% required dose reduction compared to in the arm B with 18%. Another important point that we found was that the CR rate was higher in arm A at 35% compared to arm B at 12%. This was based on the PSA percentage CR. In terms of toxicities, the grade 4 toxicity being neutropenia at 38% in the cediranib arm compared to 18% in the control arm. An important point that we've been talking a lot about today is fatigue, and that was significantly higher in our cediranib arm at 31% compared to 4% in the control arm. Also, amongst many of the VEGF inhibitors, amongst the class of the VEGF inhibitors, hypertension was more prevalent at 28% in the cediranib arm compared to the control arm. Therefore, our conclusion is that VEGF plays a role in tumor proliferation. It's known to be increased in prostate cancer. Our median 6-month PFS was higher in the cediranib arm, but it was not statistically significant. The PSA complete response rate was higher, though, in the cediranib arm. However, the benefits may also come at the expense of increased toxicity, including the fatigue, the hypertension, and also the neutropenia. We do have correlative studies still pending, including looking at, in particular, those VEGF levels to see if there are certain groups that perhaps responded better in terms of looking at correlative studies pre, during, and post therapy. And always, we're all wondering, certainly if we do find benefit, ultimately, can this translate into trials in the castrate-sensitive setting as well? But certainly, we want to get the correlative studies first. Thank you very much for your attention. I want to thank again Dr. Elizabeth Heath and the Karmanos Cancer Center. Thank you.
So just curious, does this drug have a life in other diseases? Is it moving forward elsewhere?
I know they are looking in multiple other tumor types as well. I'm recalling ovarian as one of them. I don't know if it's approved right now in terms of in the setting of therapy, but they definitely have been looking at other tumor types as well.
And with the degree of neutropenia and dose reductions, was that anticipated, or was that a bit of a surprise? Or
it was a bit of a surprise initially, because in the phase one that we had done at the Karmanos, the 30 milligrams was the dose that was seemingly accepted with the docetaxel combination.
Yeah.
It ultimately was a little bit of a surprise to us that we had to reduce to the 20 milligrams, and we saw even more dose reduction. I'm sorry, the slide wasn't up there, but yeah, even further dose reductions to 15 milligrams, many required as well.
Quick question. I don't know if it was given some thought, but we actually did the phase 1 of this drug at UCSF years ago, and we found it to be a really interesting drug. We had a lot of toxicity at 30. We had men who couldn't get up off the sofa. They had so much muscle fatigue and weakness. Yes. But then we had 3 people, again, small number, we had 3 people who came off for toxicity after, like, one of them was on for 14 days, and his PSA dropped like 6 weeks later, with no other intervening therapy, and stayed down for months and months. And I always wondered what was going on, like what were we doing with this story, and whether that would be teased out in subsequent therapies. But I guess my question is this, is if you look back at the bevacizumab studies, there was what looked like a pretty clear advantage in terms of PFS for the higher risk patient population, high LDH, visceral metastasis, that kind of thing. Mm-hmm. And I think that, I wonder if we were to try to develop angiogenesis inhibitors in the combination setting more, if that should be a patient population we should be targeting. And I mean, I know you had kind of a smallish phase 2 with a variety of patients, but right. Any hint from your work that higher risk patients may have benefited from this combination?
I think there was some hint. I mean, 40% of the patients had visceral disease as well at the start. That's certainly, I'll have to take a look back to see if we can get that. I think we can come up with that data easily to see if those were the patients that benefited more. But we definitely did have a higher risk group of patients for sure. So that's great. I'm going to take a look when I get back to Karmanos. That's great.